Hello, we're going to talk today about experimental studies. We will review their key features with a focus on randomized controlled clinical trials, or RCTs. We will also review different types of experimental studies and conclude with an examination of the main type of bias that affect experimental studies. RCTs are the most well-known experimental design and the ultimate step in testing causal hypotheses. James Lind was a Scottish clinician who conducted the first RCT in 1747 about the role of citrus fruits in treating scurvy. He selected 12 sailors, all suffering from scurvy, and divided them into 6 pairs, and gave them different additions to their basic diet for a period of 2 weeks. And then he examined how many of them improved after a follow-up period. What are the differences between observational and experimental studies? Observational studies have been called natural experiments because researchers observe a natural exposure and make inferences about the relationship between exposure to a factor and an outcome. On the other hand, in experimental studies, investigators can control the exposure. In other words, they assign study participants to intervention or control groups. Generally, this assignment is made at random. RCTs are the gold standard of research designs. In an RCT, study participants are randomly assigned to treatment and control groups, and then investigators observe over time the incidence of outcomes. RCTs provide the most convincing evidence of a relationship between exposure and effect. Many types of interventions can be evaluated in RCTs. They include drugs and new treatments, medical technologies, methods for primary prevention or screening programs, ways of organizing and delivering health services, community and behavioral intervention programs, and multimodal interventions. Key issues of RCTs include defining the type of study question, selecting the study population, allocation of the intervention, follow-up of participants and outcome assessment, and data analysis and interpretation. The effects of exposure to a treatment can only be evaluated compared to a group that has not been exposed to the intervention. RCTs might consist of different comparisons: treatments versus no treatment conditions, treatment versus placebo or sham treatment, or two treatments that are active. Randomization is the process in which allocation of participants to treatment groups is done by chance, without the ability to predict who is assigned to the groups. All participants have an equal probability of being assigned to a particular intervention, and allocation to treatment is not predictable based on any particular pattern. The purpose of randomization is to prevent bias in the allocation of participants to the study groups. Randomization balances potential confounding factors across the groups in a way that any differences observed between treatment and control are due to the treatment per se or to chance. Randomization is supposed to balance both measured and non-measured confounders. If randomization has been successful, chance should be the only explanation for any observed differences between the groups. One way to check if randomization was successful is to look at Table 1 of most RCT papers, in which baseline characteristics of treatment and control groups are presented. In this example, p-values show that baseline factors seem to be balanced. Therefore, we can assume that randomization in this case has been successful. Now, let's see what can be randomized. Units of randomization can be individuals, health providers, or communities. When allocation to treatment is made by groups, the trials are called cluster RCTs. Groups can be families, schools, towns, hospitals, any communities. Uh, some of the most important challenges of clusters RCTs are that they have a high risk of contamination for the intervention and they need advanced statistical techniques for the analysis. This is an example of a cluster RCT. This trial evaluated the effect of a pharmacist-led educational intervention to reduce inappropriate prescriptions among older adults with polypharmacy. The study population were older adults recruited from community pharmacies in Quebec. A cluster design was chosen to prevent contamination across the intervention and the control arms by individual clients going to the same pharmacy. Then the cluster and unit of randomization were the community pharmacies. There were two arms in this cluster RCT, the educational intervention arm and a control group consisting of wait list for 6 months. There are two steps in the allocation to treatment: generation of the allocation sequence or randomization and allocation concealment. The second step, allocation concealment, shields those involved in the trial from knowing upcoming assessments. Without this protection, investigators and patients have been known to change who gets the next assignment, making the comparison groups less equivalent. Allocation concealment is the blinding of the sequence of randomization. We will talk about this later. There are different methods to generate the allocation sequence. The easiest and most intuitive method is simple randomization, which consists of flipping a coin or using a table of random numbers or a computer-generated random list. One of the disadvantages of this method is that it does not guarantee balance between the groups, especially when the trials are small. Randomization can be made by blocks of participants to ensure equal balance in the size of the arms. Within each block, participants are randomly allocated into the arms, and for example, we can generate 5 blocks each containing 4 participants that are randomly allocated to the arms by block. The problem with block randomization is that it does not balance for known prognostic factors. Stratified randomization is useful if there are factors other than the intervention that might have a strong influence on the outcome. For example, age and sex might be important risk factors, and therefore we might want to do a stratified randomization by sex and age. And if we decide to do this, we would divide the study population into the strata by sex and then by age, and then randomize the individuals in each stratum of age and sex separately. This will ensure that the randomized groups will be balanced with respect to these risk factors. There are methods of treatment allocation that are not appropriate, such as date of birth, hospital record numbers, day of enrollment, or alternating by the sequence of presentation. These are not methods of randomization. Let's suppose that an investigator creates an allocation sequence using a random number table. However, he places the list of the sequence in a bulletin board with no concealment of the allocation. Then those responsible for admitting participants in the trial can guess what is the upcoming treatment and then divert participants with better prognosis to the treatment group and those with a poor prognosis to the control group or vice versa. With this practice, a bias will be introduced in the trial and will defeat the purpose of randomization. Another inadequate allocation concealment strategy would be to use translucent envelopes that might allow to guess the assignments when the envelopes are held up to a light bulb. A good allocation concealment include doing things such as having central randomization, using numbered, opaque, sealed envelopes, or using numbered or coded bottles or containers if the trial is testing a drug. The drugs in this case must be prepared by a pharmacy. This is a very famous case of allocation non-concealment reported in the literature. This was a trial of laparoscopy versus open appendectomy, in which the residents that participated in the trial, in order to avoid having to perform a laparoscopy with a grumpy doctor, um, at night they will hold the envelopes against the light to identify who was the next allocation group, and then they pick the first one with open appendectomy, which it was a procedure that they could do by themselves. Therefore, the patients that were enrolled during the day were those that were consistently allocated with laparoscopy. So in this case, the allocation sequence was completely modified because this lack of concealment. Allocation concealment should not be confused with blinding. Allocation concealment focused on preventing selection bias and safeguarding the assignment sequence before and until allocation. Allocation concealment can always be successfully implemented in a trial. On the other hand, blinding concentrates on preventing study personnel and participants from guessing the group to which participants have been assigned and safeguarding the sequence after allocation. Blinding, in contrast, cannot always be implemented in a trial. Blinding helps to increase the objectivity of the RCT. Study participants, caregivers, data collectors, analysts, and investigators can be blinded in a trial. And the level of blinding can be open when everybody in the trial knows who is getting the intervention, or single, double, or triple blinding, depending on whether only participants or participants and investigators and those responsible of data analysis are blinded or not. In trials that test against no intervention, blinding of patient and caregivers is achieved through placebos. A placebo is a medical treatment administered as if it were a therapy, but which has no therapeutic value other than the placebo effect. In cases in which surgery is the treatment under study, sham interventions might be useful. However, there are some cases, such as physical therapy or psychotherapy, in which blinding is practically impossible. Blinding is also important for follow-up and outcome assessment. So, in the follow-up, outcome assessment occur over time, and for this, it's important that the study outcomes are based on valid and reliable case definitions. For outcome assessment, it's important to assess whether only the participant or the outcome assessors or the investigators, for example, are blinded to the allocation of the intervention. Data analysis in RCTs can be by intention to treat, which is analyzing according to the original allocation, per protocol, including only those participants who completed the trial as randomized, or as treated, which is analyzing participants according to the intervention that they received, which might be different from the one they were assigned to. In this follow diagram of a trial comparing two treatment groups, we can see that there is a number of people that were allocated to the treatment, 31 and 30 respectively. But when you look at the analysis phase, ITT means that everybody that was allocated was analyzed. But in the other two types of analysis, safety and per protocol analysis, those that were lost to follow up or that did not receive the allocated intervention were excluded from the analysis. With this, we conclude the first part of this lecture. In the second part, we're going to look at the different types of RCTs and bias that might affect randomized clinical trials.